Hello everybody, this is Dr. Nadeem. We are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We have a Telegram group which you can join to access all lecture related information. We also have a Google Drive where the PDF of all lectures are available. These are the disclaimers. We are with phase 3, which is recorded pathology lectures. And today we are with Pursue 26, which is dermatopathology, which is Pursue 26O, and we are streaming from Indus Super Speciality Hospital, Mohali, India. And the topic of the day is dermal infection bacterial. And to talk on that, we have Dr. Pavithra H N. She is an MBBS MD pathology from PGI Chandigarh. Presently, she is a pathologist at the Indus Super Speciality Hospital, Mohali, Punjab. Her areas of interest being breast pathology and dermatopathology. She's got multiple publications in international and national journals. With this, I would request Dr. Pavithra to start her talk on dermal infections, the bacterial part. Thank you so much. Over to you, ma'am.
Thank you, sir. Thank you for giving me an opportunity to speak here. Today, let's discuss about dermal infections, bacterial. When we talk about skin, there are normal commensal population of bacteria, including Staphylococcus epidermidis, which predominates, along with Micrococcus species, Corynebacterium species, and so on. Most common cause of superficial bacterial infection include Staph aureus and Streptococcus pyogenes. This is caused by staph and streptococcus include Impetigo, ecthyma, Staphylococcus scarlet skin syndrome, Erysipelas. Mycobacterial infection include leprosy, tuberculosis. Along with this, we will read about a few more bacterial infections of the skin. Impetigo. These are very common superficial pyogenic skin infections, highly contagious, occurs in childhood, elderly, and in immunodeficient. Usually follows contamination of minor skin abrasions and insect bites by Staph aureus or Streptococcus pyogenes. Impetigo can be simple, which is known as Impetigo contagiosa or Bullous impetigo. Impetigo contagiosa, small superficial vesicles which rapidly burst and are replaced by characteristic adherent thick yellowish dirty crust with a margin of erythema. Affect mouth, nose, and extremities, may occur in epidemic or endemic form, often spread to siblings and schoolmates. Bullous impetigo, exclusively due to phage group 2 Staph aureus. Superficial blisters up to 2 cm across are the initial features. The contents are at first clear, rapidly become cloudy, and then develop a thin seropurulent crust. Do not usually involve mucosae. There may be mild constitutional symptoms. Lesions usually resolve in 2 to 3 weeks. On histology, the early lesions are characterized by a split in the epidermis and just beneath the stratum granulosum. The resultant vesicle becomes filled with neutrophils, gram-positive cocci, and occasional acantholytic cells. Condylimine dermis contains mixed neutrophil and lymphocyte infiltrate. Neutrophils may be seen in the spongiotic stratum spinosum beneath the vesicle as a part of chemotactic response. In this picture, we can see the intraepidermal bulla filled with inflammatory infiltrate. Predominantly, you can see these are neutrophils. There is dermal infiltrate also. Ecthyma predominantly involves lower limbs in children. In adults, it can involve other sites also. They present with thick crust overlying punched out ulceration and scarring. Streptococcus pyogenes is the usual cause. Most commonly, these are seen in tropical climate. This picture, we can see there is thick crusting overlying punched out ulceration, scarring. Ecthyma gangrenosum, usually a complication of Pseudomonas aeruginosa septicemia that occurs in immunodeficient patients, particularly those with neutropenia. They begin as painless erythematous macules that become indurated, bullous, or pustular. Lesions soon become gangrenous, covered by characteristic gray-black eschar and erythematous halo. They are especially seen on gluteal perineal lesions and on the limbs. Mortality is high, particularly in those with multiple lesions. This is purpuricula with surrounding erythema. Ecthyma, histologically, they are sharply circumscribed area of ulcerations with heavy neutrophilic infiltrate and overlying adherent crust. Ecthyma gangrenosum, epidermal necrosis can be seen with hemorrhage and dermal infarction. They are usually accompanied by mixed inflammatory cell infiltrate of lymphocytes, neutrophils, histiocytes. You see gram-negative bacilli in the dermis, which involves median adventitia of venules. Vasculitis and thrombosis may be present. So here you can see ulceration of the epidermis, which is sharply demarcated and is densely filled with cells, which we can see as neutrophils. Staphylococcal scarlet skin syndrome. There will be presence of staphylococcal toxin and they have resemblance to established region of the skull. So this is how it gets the name staphylococcal scarlet skin syndrome. It may present in epidemic as well as sporadic forms. Relatively, they have abrupt onset, occurs almost entirely in neonates, young children. Often associated fever, irritability, and skin tenderness are identified. The eruption spreads to other sites, including conjunctiva. Mucous membranes are usually spared. Skin becomes edematous and surface fragile so that it can be sheared off in thin wrinkled sheets, leaving a glistening red surface, and the child becomes sick, feverish. Therefore, it is associated with the Boston-Nikolsky sign. Usual source of infection may be from the upper respiratory tract infection, conjunctivitis, umbilical sepsis. In this picture, we can see the peeling of the skin. In neonates, stir disease. Usually, it is a self-limiting with rapid resolution of the skin blisters and complete recovery. Another type is abortiform, the scarletiniform variant, which is a staphylococcal scarlet fever. Initial erythroderma evolves into the desquamative phase in the absence of blisters, may be particularly associated with occult bone and joint infections or contaminated wounds. On histology, the cleft through the granular layer of the epidermis are associated with only scanty inflammatory infiltrate in the epidermis or dermis. There may be some dermal edema and dilatation of the superficial vascular plexus. The adjacent epidermis does not show necrosis and acantholysis is variably present. These include toxic epidermal necrolysis, where subepidermal blister with a necrotic epidermal roof and moderately intense lymphocytic infiltrate is in the dermis. But in staphylococcal scarlet syndrome, the separation is through the granular cell layer. Otherwise, even sand smear can be useful, where you see necrotic keratinocytes with inflammatory cells in toxic epidermal necrolysis and variable acantholytic keratinocytes without inflammatory cell in staphylococcal scarlet skin syndrome. Erysipelas. They are classically a group of A beta hemolytic streptococcal infection caused by Streptococcus pyogenes. They usually affect skin of the face, sharply outlined edematous, erythematous, tender and painful blocks will be seen. Lesions are initiated by inoculation of minor abrasion or splits in the epidermis. Proliferation of the organism is associated with the production of enzymes facilitating the extension of bacteria in the skin. This is one of the pictures. On histology, the conspicuous features are dermal edema and lymphatic dilatation, diffuse heavy neutrophilic infiltration with limited localization around the blood vessel, vascular and lymphatic dilatation, and RBC extravasations are variable feature. In later stages, some lymphocytes, histiocytes are also seen, and granulation tissue may be present deep to the zone of subepidermal edema. Bacterial infections, mycobacterial infections, tuberculosis and leprosy, as you know, are intracellular parasites. Leprosy. This is also known as Hansen's disease. It's a chronic granulomatous infection caused by Mycobacterium leprae, which is an obligate intracellular gram-positive, weakly acid-fast organism. Predominantly affects skin and peripheral nerves. Mode of transmission. Exact mode of transmission is still not known, but it is thought to be probably through the inhalation of the bacilli, very rarely person to person contact. For this to occur, prolonged close contact with someone with untreated leprosy over many months is needed to catch the disease. And it is endemic in tropical subtropical countries. Prevalence declined due to multi-drug therapy. So, the spectrum of leprosy is a continuous spectrum, and the standard deviation follows Ridley and Joplin deviation, which is a combination of clinical, microbiologic, histopathologic, and immunologic illnesses. So the spectrum of leprosy includes tuberculoid leprosy, borderline tuberculoid, mid-borderline, borderline lepromatous, and lepromatous. The TT and LL are the stable forms. TT is self-healing and LL is heavily infected. BP is the most stable of unstable of all this, and BP downgrade to LL without treatment. In indeterminate leprosy, it presents with very early leprosy lesions, cannot be categorized technically along the spectrum. It has a potential to self-heal or evolve into TT, PL, or LL leprosy. Bacterial indices. So the Ridley's logarithmic scale applies to both skin biopsies and split skin smear. And based on this, so when there are no bacilli, we give us bacterial index 0 and 1 when 1 to 10 bacilli in 10 to 100 high power fields. Bacterial index 2, 3, 4, 5 goes on as to 1 to 10 in 1 to 10 high power field, 1 to 10 high power field, 10 to 100 bacilli per in high power field, or 100 to 1000 bacilli per high power. What is the pathogenesis in leprosy? The defect is in the cell-mediated immune response to the leprobacilli. This is purely for leprobacilli, while the defect is specific for this, but not for the other antigens. So, when there is defect in the cell-mediated immune response to leprobacilli, the body cannot eradicate this organism spontaneously. The primary defect lies in T lymphocytes. They further do not adequately activate macrophages to destroy phagocytized bacilli. In early indeterminate leprosy, the earliest detectable skin lesions comprise one or a few hypopigmented macules with variable loss of sensation, affect any part of the body, and often resolve spontaneously. There will be mild lymphocytic and macrophage accumulation around the neurovascular bundles, focal lymphocytic invasion to the lower epidermis and into the dermal nerves may be observed. No formed epithelial cell granulomas. Schwann cell hyperplasia is a feature, but it is highly subjective. Diagnosis hinges on finding one or more lepra bacilli in the sites of predilection, which include nerves, rectopillar muscle, just under the epidermis, or in the macrophages above the vessel. Lepromatous leprosy occurs in patients with poor cell-mediated immunity to Mycobacterium leprae. Initial changes are seen in skin and mucosae. Neural changes occur later. Lesions are typically firm, nodular, concentrated on the face and back, facial lesions being associated with hair loss around the eyes. Lesions distribute in an area where there would be low skin temperatures. Lepromatous leprosy can be like macular type, where there will be numerous ill-defined confluent, either hypopigmented or edematous macules. They are frequently slightly infiltrated. They can be infiltrative nodular type, which is the classical and most common form, may develop from the macular type or arise as such. It is characterized by papules, nodules, and diffuse infiltrates that are often dull red. Involvement of eyebrows and forehead often result in leonine faces with the loss of eyebrows and eyelashes. The lesions themselves are notably hypoesthetic, although through involvement of large peripheral nerves, disturbances of sensation and nerve valves develop. Nerves that are most commonly involved are ulnar, radial, common peroneal nerves. Another type is the diffuse type of lepromatous leprosy, which is a severe type and is called Lucio leprosy. It is recognized that the causative agent is Mycobacterium lepromatosis. Diffuse infiltration of the skin is seen without nodule formation. This infiltration may be quite inconspicuous except for alopecia of the eyebrows and eyelashes. Acral symmetric anesthesia is generally present. Histopathology leprosy. It's a distinct variant of lepromatous leprosy characterized by well-demarcated cutaneous, subcutaneous nodules resembling dermatofibromas. On histology, the inability to develop significant T-cell mediated delayed hypersensitivity response is the cause in leprosy. So usual macular or infiltrative nodular lesions, they will be extensive cellular infiltrate, invariably separated from the flattened epidermis by a narrow blood zone or normal collagen. Superficial, deep, and perivascular or periadnexal infiltrate of foamy histiocytes would be present. The infiltrate may cause the destruction of cutaneous appendages and extends into the subcutaneous fat. The macrophages are inert, have abundant eosinophilic cytoplasm, extended with large globi of leprosy bacilli. Bacilli are commonly observed in endothelial cells as well. No macrophage activation is seen, so there is no epithelial cell granuloma formation. Lymphocyte infiltration is not prominent, but there may be many plasma cells. On H&D stain, the bacilli give the cytoplasm grayish tinge on staining. The bacilli are revealed more clearly with modified Ziehl-Neelsen stain or Wadefide stain. So in this picture, you can see there is a clear gray zone just beneath the epidermis, and you can also see that the dermis shows collections of foamy cells foamy macrophages, which are globi. Acid Zeal-Nielsen, modified Zeal-Nielsen staining detects the bacilli. And in lepromatous leprosy, in time and with antimycobacterial therapy, the bacilli degenerate and accumulate in the macrophages, the so-called lepra cells or Burko cells. They have foamy vacuolated cytoplasm. And in contrast to tubercular leprosy, which we'll be studying in a while, the nerves in the skin may be containing considerable amount of leprosy bacilli. They remain well preserved for a long time and slowly become fibrotic. On treating lepromatous leprosy, the bacilli die rapidly, become fragmented within weeks or months, and can take several years for the bacterial debris to be cleared by host macrophages. Lucio leprosy. The histology is similar to lepromatous leprosy, but there is characteristic heavy bacillary infiltrate in the small blood vessels of the skin. And Histopathology leprosy, the highest loads of leprobacilli, majority are solid staining, arranged in clouds, like sheaves of wheat. The macrophages frequently become spindle-shaped and oriented in storiform pattern, similar to fibrous histiocytoma. The epidermis may be stretched over such dermal expansile nodules. This is a picture where we can see the spindle cells arranged in storiform pattern, and there are some inflammatory cells in the background. Borderline lepromatous leprosy. The lesions are less numerous and less symmetrical than lepromatous leprosy lesions. They are often displaying some central dimples. Lymphocytes are more prominent. Tendency for some activation of macrophages to form poor or moderately defined granulomas as seen. Typical perineural fibroblast proliferation forming an onion skin in cross section. Foamy cells are not prominent. Globi do not usually accumulate. Bacterial index ranges from 4 to 5. With borderline leprosy, the skin lesions are usually irregularly dispersed, shaped erythematous blocks with punched out centers. There is uniform activation of macrophages to form epithelial cells. However, no distinct granulomas may be seen. Lymphocytes are scant. You don't see Langhans giant cells. Bacterial index ranges from 3 to 4, and dermal edema is prominent between the inflammatory cells. Borderline tubercular leprosy. You see asymmetrical lesions, which may be scanty, dry hairless blocks with central hypopigmentation, nerve enlargement may be there. Lesions are usually anesthetic. On histology in borderline tuberculoid, there may be granulomas with peripheral lymphocytes. They follow the neurovascular bundles, infiltrate sweat glands, erector pili muscles. Langhans giant cells are variable in number and are not large in size. They do not infiltrate up to the epidermis. The nerve erosions may be seen. Nerves may be obliterated. Scanty bacilli, bacterial index ranges from 0 to 2. Bacilli are most readily found in the Schwann cells of nerves. IHC S100 may be helpful in demonstrating the destroyed nerves or the nerves surrounded by granulomas. Tuberculoid leprosy. Skin lesions will be scant, dry, erythematous, hypopigmented papules or blocks with sharply defined edges. Anesthesia may be prominent on the face. Number of lesions ranges from 1 to 5. Thickened local peripheral nerves may be found. Lesions heal rapidly on therapy. On histology, Large epithelial cells arranged in compact granulomas are seen. Neurovascular bundles with dense peripheral lymphocyte accumulation. Langhans ring cells are typically absent. Dermal nerves may be obliterated, surrounded by dense lymphocyte cuffs. Bacilli are rarely found even in the nerves. Coming to leprosy reactions, there are mainly two types of leprosy reactions, and there's a third reaction which is specific to Lucio multibacillary leprosy. Type 1 reactions. They shift toward the tuberculoid pole, which is upgrading or reversal reaction, or there can be shift towards the Lepromatous pole, which is a downgrading reaction. Both are aspects of delayed hypersensitivity or type 1 reaction to leprosy. In type 1 reactions, the TT patients are stable, as we discussed earlier, and PT patients may downgrade without treatment. Multibacillary patients, particularly those with BL point, frequently upgrade on chemotherapy. About 1/4 of them exhibit significant reactions. PB patients are most unstable and will move in either direction depending on the therapy and often present with reactions. Most common aspect type 1 reaction is that condition of the peripheral nerves and not of the skin. Both have inflammatory process, induce increased intraneural inflammation and edema, which is damaging. At worst, there is caseation necrosis of large peripheral nerves resulting from upgrading reactions. The distinction between upgrading and downgrading reaction is difficult to make and may require serial examination. Typically, edema within and about the granulomas and proliferation of fibroblasts in the dermis. Upgrading reaction. Granuloma becomes more epithelial and activated. Langham giant cells become larger. There may be erosion of granulomas into the lower epidermis. There may be fibroid necrosis within the granulomas and even within dermal nerves. In downgrading reactions, necrosis is much less common. Over time, the density of bacilli increases. Multibacillary leprosy patients who upgrade on therapy show old foamy macrophages and degenerate bacilli and mix with newly developing epithelial cell granulomas. Type 2 reactions, so known as erythema nodosum leprosum. They occur most commonly in LL leprosy and less frequently in BL leprosy. Seen in patients under treatment or in patients untreated. This is the only type of leprosy reaction which responds to thalidomide. Clinically, it resembles erythema multiforme. The patients have tendinous red skin blocks and nodules together with areas of erythema. Ulcer is rare, the eruption is widespread and accompanied by fever, malaise, arthralgia, and leukocytosis. On histology, you can see foci of acute inflammation imposed on chronic multibacillary leprosy. Neutrophils may be scanty or abundant to form a dermal abscess with ulceration. Foamy macrophages containing fragmented bacilli are usual. Anti-mycobacterial immunohistochemical state like BCG will indicate abundant antigen. Patients may have superficial ulceration, necrotizing vasculitis affecting arterioles, venules, and capillaries. In this first picture, you can see there's focal vasculitis involving capillaries. Second picture, there is arteriolar involvement with fibrinoid necrosis and endothelitis. Here, there's collection of macrophages infiltrated by neutrophils. Last picture, eosinophil infiltrate and mix with neutrophils. This picture, you can see there is then inflammatory infiltrate around the dermal vasculature and inflammation extends into subcutaneous pattern. Lucio reaction occurs exclusively in diffuse lepromatous leprosy. It's a very common complication of lepromatous leprosy usually occurs in patients who have received either no treatment or inadequate treatment. Lesion consists of barely palpable hemorrhagic, sharp, marginated, irregular plaques, develop into crusted lesions or to ulcers in legs, especially. There may be repeated attacks or continuous appearance of new lesions for years. On histology, vascular changes are critical. Endothelial proliferation leading to luminal augmentation is seen in association with thrombus in the medium-sized vessels of dermis and subcutis. Sparse, largely mononuclear infiltrate, dense aggregates of acid-fast bacilli found in the walls and endothelium of normal-appearing vessels and vessels with proliferative changes. Ischemic necrosis, brought on by the vascular occlusion, leads to hemorrhagic infarcts and result in crusted erosions or frank ulcers. Staining is by modified Sedan stain, use 5% HCl, 20% as against tuberculous bacilli, verified method, methanometilber, and bacilli usually measure about 5 by 0.5 microns. So, sensitivity of modified Sedan stain on histological sections is poor, and solid staining indicate that organisms are capable of multiplication. Fragmented, beaded, or granulous as fast bacilli indicate they are dead. Next is tuberculosis. Cutaneous tuberculosis form around 1 to 1.5% of the extrapulmonary tuberculosis and around 0.14% of all cases of tuberculosis. Majority of the cases, there is manifestation of systemic disease. Usual portals of entry include lungs and intestine. Mucous membranes and skin occasionally show primary involvement also. What is the source of infection? They can be exogenous, endogenous, hematogenous spread, any of these. And these bacilli, they are highly resistant to drying and can retain infectivity by inoculation or contamination of minor wounds. Tuberculosis reaction depends on size of the inoculum, virulence of the organism, and immune state of the patient. The cellular reaction or cellular response is characterized by epithelial macrophages, Langerhans giant cells, and caseous necrosis with lymphocytes and plasma cells in the surrounding tissue, forming tuberculous granuloma. They show true caseation. Presence of large number of bacilli in the skin implies non-immune or allergic state, like tuberculous chancre or orificial lesions. Caseation is an indication of hypersensitivity and not the toxic effect of the organism. Depending on the amount of bacilli, whether they are readily identified or needs extensive searching, they can be multibacillary forms or paucibacillary forms. Multibacillary forms include primary tuberculosis, scrophaloderma, tuberculosis cutis orificialis, acute miliary tuberculosis. And paucibacillary forms include tuberculosis varicosa cutis, tuberculosis gamma, lupus vulgaris, tuberculosis, lichen sclerosa. So in this picture, you can see that there is caseation necrosis. There is necrosis of the cells, but they have maintained outline. So that gives them the granular appearance. Here you can see a well-formed epithelial cell granuloma with Langerhans giant cells. These are multinucleated giant cells with peripheral horseshoe-shaped ring of nuclei. And there is abundant lymphoid infiltration in the surrounding tissue, or lymphoid cuffing around the granulomas. Coming to cutaneous lesions, so let's start with primary chancre. It is characterized by neutrophilic abscess with numerous bacilli associated with necrosis leading to ulceration, gradually surrounded by histiocytes, and after 6 weeks, you can see giant cell formation. There is central necrosis, which is prominent, that diminishes along with the number of bacilli as the granuloma becomes prominent. What is lupus? It is characterized by acanthotic papillomatosis with marked hyperkeratosis. There may be pseudoepitheliomatous hyperplasia, dermal infiltrate mainly of neutrophils and lymphocytes. Abscesses may sometimes be present, granulomata present in deeper dermis. Caseation is occasionally regional. Bacilli are found on careful searching. Here you can see there is hyperkeratosis of the epidermis with epidermal hyperplasia and xanthosis. Dermal infiltrate can also be seen. Orificial lesions. They are extensive necrosis and numerous bacilli can be detected. May consist of lymphocytes and neutrophils between osteocytes. Granulomas not conspicuous. Lupus vulgaris typically presents around the nose, presence of large venous channels with stasis of blood, relative cold and hypoxia which impair fibrinolysis and host defense. May affect other areas with relatively low temperatures and will have varied histological features. You can see in the superficial dermis which consists of tubercles, some of which coalesce with scant or absent central caseation, surrounded by epithelial histiocytes and multinucleated chain cells. Peripheral lymphocytes, plasma cells are also usually prominent. Bacteria are very infrequent. Overlying epidermis may be ulcerated, atrophic, or acanthic. Here you can see there is abundant dermal infiltrate in case of lupus vulgaris. Extensive necrosis, abscess formation will be present, and then cells are arranged. Scrophulodontia usually appears as an ulcerated dermal abscess with an ill-defined histiocytic component. Peripheral granulomata may be present. Marked caseation necrosis, in which bacilli may be numerous, can be seen in the deeper tissues. Tuberculous stomata. Subcutaneous stomata are associated with marked caseation, but few bacilli. Tuberculous cellulitic lesions are characterized by granulomatous inflammation with giant cells and demonstrable bacilli. Panniculitis with vasculitis may occasionally be seen in cutaneous lesions. Case of lupus vulgaris, where you can find epithelial cell granuloma and lymphoid cuffing. In scrophulodontia, you can see abundant caseation necrosis. Biliary tuberculosis, you can see granuloma with giant cells and neutrophilic infiltrate. Tuberculous gamba, you can see necrosis again along with granuloma. Infections with non-tuberculous mycobacteria. Mycobacterium marinum is common among immunocompetent people. Non-tuberculous mycobacteria are abundant in nature, in soil and water in contact with most zones of the world is frequent. Infection with Mycobacterium cancer. So usually lymph node and pulmonary infections are seen. Skin lesions are usually unusual. The skin lesions are acute abscesses with large number of bacillus bacilli. Mycobacterium avium intercellulare, common cause of cervical lymph node mycobacteriosis in normal children and of pulmonary disease in previously damaged lungs. Most of the lesions are solitary, consist of indolent, dusky, red, hyperkeratotic papillomatous papules, nodules, or plaques. Areas of necrosis are only occasionally present in the centers of granulomata. Epidermis often shows marked hyperkeratosis with an acute inflammatory infiltrate and ulceration. This is a tabular column to distinguish these types of tuberculosis, cutaneous tuberculosis. In tuberculous chancre and warty lupus, the infection is through inoculation, orificial lesions through autoinoculation. Lupus vulgaris can be through inoculation or hematogenous spread. Scrophaloderma due to extension from underlying infection, tuberculosis gamma, and miliary tuberculosis due to hematogenous spread. All these are associated with other tuberculosis except for tuberculous chancre. Tuberculous chancre, warty lupus, and biliary tuberculosis extend up to dermis. Orificial lesions cause submucosa dermis. Lupus vulgaris is in superficial dermis. Scrophaloderma and tuberculous gamma can extend up to subcutis. Histological features, as we have seen in tuberculous chancre, this neutrophilic abscess caseating granuloma lymphadenopathy. Warty lupus, scant granuloma, papillomatous acanthosis, orificial ulcers with mild inflammation, few granulomata necrosis. Lupus vulgaris, variable but granuloma and caseation present. Scrophaloderma, mixed inflammation, granuloma, fibrosis. Tuberculosis gamma, there is much caseation, granulomatous fibrosis. Biliary tuberculosis, central abscess with surrounding histiocytic infiltrate. Tuberculous chancre, bacilli will be present. They're absent in warty lupus, numerous in orificial lesions. In lupus vulgaris and scrophaloderma, they may be present in the deeper aspect. Tuberculosis gamma, they are scanty again, and in biliary tuberculosis, absent or scanty in benign form, and they are present in aggressive forms. Details include sarcoid granulomas. As you know, these are naked granulomas, or they deep fungal infections, leishmaniasis, or granulomas of late secondary or tertiary syphilis. Tuberculosis. Cutaneous immunological reaction to the presence of tuberculosis, which is often occurred elsewhere in the body. They are immunological reactions thought to be due to a hematogenous dissemination of mycobacterial tuberculosis antigens or small number of dead bacteria, possibly opsonized. By definition, special strains and cultures for tubercle bacilli form tuberculosis are negative. Maybe papillar or nodular lesions like papillonecrotic tuberculate, lichen scrophalocerum. Lichen scrophalocerum presents as yellow or brown asymptomatic follicular papules less than 3 mm across on the trunk. Lesions regress slowly and do not leave scars. Uncommon tuberculous reactions usually in children and young adults. Said to be more frequent with tuberculous lymphadenitis or osseous tuberculosis than with pulmonary tuberculosis. Granulomatous infiltrate can be seen with conspicuous Langhans cells centered around hair follicle and eccrine units. Caseation is usually absent. That's about tuberculosis. Next, coming to treponema diseases. They are caused by motile bacteria of family Spirochaetaceae. Venereal disease, non-venereal disease can be distinguished. In endemic syphilis, it's non-venereal diplomatosis caused by Treponema pallidum subspecies endemicum, usually occurs in children living in conditions of poor hygiene, transmitted by cutaneous inoculation. Venereal syphilis. In primary syphilis, it is defined by skin lesion or chancre in which organisms are identified, typically arise 21 days after exposure at the inoculation site. Painless brown-red indurated round papule nodular block 1 to 2 centimeters in diameter. Lesions are multiple or ulcerative, and the regional lymph nodes may be enlarged. Secondary syphilis results from hematogenous dissemination of organisms. Generalized eruption comprises brown-red macules and papules, papulosquamous lesions. Lesions may be follicular-based, annular, or serpiginous. Alopecia condylomata in anogenital areas, bitter hyperkeratotic papules, which are palmar plantar papules, termed syphilis cornea. Interstitial syphilis, comatous skin and mucous lesions, cardiovascular manifestation, neurologic manifestations would be present. The skin lesions may be solitary or multiple, can be divided into superficial nodular and deep comatous lesions. The nodular type has a smooth atrophic center with a raised serpiginous border. Comatous lesions present as subcutaneous swelling that ulcerate. Fundamental pathology changes in syphilis include swelling and proliferation of endothelial cells, perivascular infiltrate of lymphoid cells, and plasma cells. In secondary and tertiary syphilis, granulomatous infiltrates comprising of epithelial or histiocytes and mosaic cells present. Newborns with congenital syphilis, there can be multi-organ involvement by angioinvasive CD68 first-year mononuclear cell infiltrate that imparts an onion skin morphology to involved vessels with numerous demonstrable spirochetes at autopsy. On histology, the epidermis at the periphery of the chancre shows acanthosis, punctuosis, exocytosis of lymphocytes and neutrophils. Towards the center, the epidermis becomes thinned, edematous, and permeated by inflammatory cells. The papillary dermis is edematous. Dense perivascular interstitial lymphohistiocytic plasma cellular infiltrate spans the entire thickness of dermis. The lymphocytes are principally of T helper type. Neutrophils are often unmixed. Demonstration of spirochetes. The silver staining with like Warthin-Starry stain, Lavarity stain, have the spirochetes are rarely seen in their full length, which is 8 to 12 spiral convolutions, each measuring from 1 to 1.2 microns in length. IHC with antibodies to treponemal antigens also help. On electron microscopy, they are 8 to 16 microns in length with regular spirals, wavelength of 0.9 microns with an amplitude of 0.2 microns. Cytoplasmic body 0.13 micron in diameter with tapered ends, all enveloped by 7 nanometer trilaminar cytoplasmic membrane. Next, actinomycosis. Actinomycosis is commensal in the human mouth. It's a gram-positive, non-acid-fast, microaerophilic bacterium with filamentous branching organisms. Most common manifestation is cervicofacial actinomycosis. Lesions have the features of chronic abscess, sinuses, containing pus surrounded by fibrosis and mixed inflammatory infiltrate. Locules separated by granulation tissue. Sulfur granules of intertwined bacteria are seen radiating mycelial filaments, often with opaque clubs at its tips. Granules may be associated with splendor Hobley phenomenon. So you can see bacterial colony that lies in the center of an abscess, and here you can see the splendor Hobley phenomenon. The club-shaped ends are present at the periphery of these granules. Rhinoscleroma, usually seen in young adults, linked to poor socioeconomic status. It is severe chronic infection of upper respiratory tract, especially nose, contracted via droplet infection. Causative organism is Klebsiella rhinoscleromatis. It's a gram-negative aerobic diplobacilli. Incubation period is very long, so that presentation is most often in adults. Organism is phagocytized but not killed by neutrophils. When the neutrophils rupture, this still viable bacteria were phagocytized by histiocytes, which become greatly distended. Wharton story or Simsa staining reveals that these vacuoles contain bacteria. Characteristics of the disease are 10 to 100 micron cells, which are termed maculic cells, and Russell bodies, dense infiltrative plasma cells, and lymphocytes. You can see lymphocytes, numerous plasma cells, forming macrophages, which are the macular cells. And the insect is a Vati sari stain to detect bacilli. Bacillary angiomatosis. It's a vasoproliferative lesion seen predominantly in the skin. It is described by immunocompromised and both in immunocompromised and apparently normal individuals. Patients present with widespread, numerous blood red, smooth surface, superficial papules, and skin colored or dusky cutaneous body. The condition may be caused by Bartonella or less frequently by Quintana. Bacillary angiomatosis. On histology, you can see lesions. Bacillary angiomatosis. On histology, you can see lobules of capillaries with prominent, often cuboidal vascular endothelial cells. ATP and mitosis may be present, sometimes surrounding ectatic vessels, among which are dispersed neutrophil infiltrate showing leukocytoclasis and purplish granules of bacilli. Bacilli are identified by Warthin-Starry reaction, Giemsa stain, and PCR reactions. Superficial lesions have polypoid configuration and they may be associated epidermal collarate reminiscent of pyogenic granule. Ulceration is seen occasionally. You can see dense nodular lesion with proliferating capillaries like nectatic vessels. Endothelial cells are swollen with conspicuous neutrophils. Inside is silver stain, Warthin-Starry stain to detect the bacteria. These are my references. Some of my references along with this I have taken from some of the journals which I have acknowledged along with the pictures.